Bundle payments offer sort of a package price for all of the services related to either a specific procedure or to treatment of a given condition. It creates an incentive for people to work together. Our fee-for-service piecework payment system creates no incentives for people to work together. We have stovepipes all over the place. Nobody talks to one another because there's no reason for them to do so. Bundle payment gives reason for people to talk to one another because they're getting paid a package price for all of their services together. The goal is to drive out cost variation and to drive out efficiency with a focus on getting rid of avoidable complications. It works essentially as a warranty. So you're saying if you pay, say, a hospital and a group of physicians together for a procedure, here's the price that we're giving you for this procedure. If you can drive out waste, reduce complications, then you can earn a margin. If you can't, and it costs you more than what this price is, then that's on you. So it's clearly transferring some financial risk, but it's transferring financial risk for performance. An example, hip replacement. So what would it include? It would include the surgery, pre- and post-operative appointments, rehabilitation, and if there are any complications, the patient needs to be readmitted. That comes out of the singular payment. So this takes away that volume incentive a little bit. It also creates an incentive for quality. So no longer are we rewarding, say, the surgeon in the hospital for a poorly performed surgery that requires the patient to come back in and have it redone. Examples of success. It's the federal Medicare program that actually has championed this payment model and has been out ahead of private payers. CMS began piloting this concept. They did 2 different pilots, and both of them yielded clearly identifiable savings. That's a big deal because, frankly, most Medicare pilots that try to pay for things differently or deliver care differently don't generate savings. This one did. It generated savings a couple times. So this is sort of a take the money to the bank strategy much more than some others. There are employers that are exploring this. In Illinois, the Employers Coalition on Health is moving towards bundle payments, but they haven't done it yet. In Minnesota, 2008, there was legislation that not only addressed healthcare homes, but that also tried to advance bundle payments. Here again, a different Minnesota term. It's baskets of care in Minnesota. There has not been much traction among payers and providers for baskets of care. There were work groups that developed 7 baskets, but implementation really stalled when people began talking about, well, how do we implement this? I will note that Minnesota Bridges to Excellence is working on a bundle payment for spine surgery. But aside from that, at least I couldn't identify a lot of bundle payment activity going on within the state. I have heard that there are providers who have gone to payers and said, we'd like to enter into bundle payment arrangement with you, but these have not seen fruition, at least based on my knowledge. Pros and cons. Strong incentive to reduce costs for both volume and price, although only for volume in terms of driving out errors that would cause rework. There's an incentive for quality, usually built into the payment methodology, and there's good evidence of success, at least with the Medicare population. The con, the bundles exist today for a limited number of conditions and procedures, although it happens to be for those that represent a large portion of spending, but you can't do it for everything. There's no incentive to reduce the volume of the procedures, only the efficiency. So if we thought that, and I'm not saying I do think, but if we thought that a hip replacement surgery was being overdone, there's no incentive to reduce the volume. There's just an incentive to make sure that they're efficient and high quality. And then last, they are administratively complex to administer. I did a study a year ago looking at all the bundle payment initiatives across the country. They are complicated to administer for both the provider and for the payer. The payment systems that insurers have are not set up to administer them, and so they're complicated for that reason.
Michael?
Yes?
Can you, so you mentioned the provider, the payer, the complication. Can you speak a little bit to the impact on the employee, the consumer, the patient, whatever you want to call them? So is it confusing for them if they're covered by a bundle because they have to do certain things, or is it?
No.
Okay.
No. I mean, a little bit like my description of healthcare home or medical home, this isn't really all that visible to the employee. So if I find out that, you know, I need to have bypass surgery, I don't really know that my insurer and the surgeon that I'm seeing in the hospital have a bundle payment arrangement. And I would say, in general, one of the lessons learned from our early incursion into managed care that involves some payment reform is everyone's learned the lesson that if we're going to change payment, we have to do so in a way that doesn't that doesn't involve the employee in a way that's in some fashion limiting to the employee. So the new payment methodologies really are much more behind the scenes and don't intrude on employees the same way.
Why can't private payers just jump on the Medicare bandwagon and take what they've learned and spread it?
They can.
Medicare has saved money.
Yeah, Medicare saved money. There are bundle payment technologies that exist. So there's what Medicare is doing. Medicare is in the process of expanding what they're doing. There are also there are a large number of commercial insurers. In fact, I can tell you that all of the major national commercial insurers have bundle payment pilots going on right now in multiple states. So it would be possible for any of you to approach your insurer and say, we'd like you to start doing this now. They could do it. My point on the administrative challenges is that it takes some work, but could it be done? Yes. I mean, there's an organization, actually the same organization that created Bridges to Excellence, created a bundle payment technology called Prometheus Payment. They've defined the bundles down to the detailed code level. They've got software to administer it. So it's a little bit off the shelf in terms of there being a technology available. You could have your health plans do this, but you would need to give them a nudge to have them do so. Okay, before I go into total cost of care, any additional questions any of you have? Yes?
No, I don't know that this is a question, but it's a comment on the whole system. I wonder if more people understood how the payment systems work. I mean, they might become fierce, afraid of it, or they might band together and try to help if they thought their care would be better. But, that's kind of, a lot of patients have no idea how the money works.
Absolutely, they have no idea.
If they did, they might make better decisions because they know where the incentives are.
Right. I mean, if you're sitting with your doctor and your doctor says, well, yeah, I'd like to do this test with you, if you are sitting there as a patient and you know that, that there's a financial benefit to the provider who's recommending that test, you might engage in a different dialogue. And again, I very carefully, I'm not pointing any fingers. In fact, my dad's a physician. But those are the financial incentives that we've created or that we have allowed to persist. And frankly, I don't think they're going to change unless you demand that they change, because the status quo works pretty well for everybody else, except for the payers. That was a point that Linda made, that the only people that are harmed are the people paying the bill. And that's you, and it's also your employees who've got to pay, higher and higher contributions all the time.
And it's the employee
that might not be necessary. Yeah, I mean, I know that I find it totally aggravating when I call my primary care physician and I don't need to be seen in the office, but they insist that I come into the office. Why? Because they don't get paid to talk to me on the phone. They get paid if I come into the office. That's not patient-centered care. That's not convenient for me. It's not what I want for my care. Yes?
So if we look at the trends, critical shortage of primary care physicians, costs that are out of control, plan sponsors that never asked to be purveyors of healthcare, they were forced with it during World War II. Why are we using more technology today? Why aren't we, you made the comment of, you're asked to come in, you may not feel as a patient that it's necessary to come in and you're taking control of your own health, which is what I think we should all do. Why isn't there more use of remote technologies? I met a CEO from a company called Teladoc. I knew nothing about him except for the fact that there's this model where at Home Depot, they change their benefit plan structure. If you feel the need to see a doctor and you feel it's not necessary to see a doctor face to face, they raise the per member per month $1.50 a month, and for you to go see a virtual doctor, it's zero copay out of your pocket. Why aren't we promoting more cost savings initiatives from the payer's perspective to drive the cost down and remove wasteful spending?
You can. I mean, I think that's a question for everyone else in the room. You can do that.
Thank you.
So for a lot of ways, this medical spending is really more of a, almost like a CYA, practice of medicine. Doctors perform more tests, so for a litigious reason, they want to cover themselves in case something else happens. Is there a talk about, tort reform or this bundle of payments to help the providers? Because you have to incentivize them.
Yeah, I've looked at the literature on this because this is a point that's frequently made by the medical community, by organized medicine, that the big problem is potential liability. Research that's looked at costs that relate to CYA medicine does not support the fact that a substantial part of spending and spending growth is due to concerns about liability exposure.